Okay. Hi, so thanks to the Center for Rare Disease Therapy for inviting me to talk today about common variable immunodeficiency. I am Chong. I am the Division Director of Allergy Immunology. I run a primary immunodeficiency clinic here on Mondays, where we take care of a lot of people with immunodeficiency. And one of those immunodeficiencies is common variable immunodeficiency, and I titled this "Or Not," just to show you that sometimes there are other things to think about and look for when someone comes and presents with an immune system issue. So our objectives is to just get a general understanding about the immune system, and then that way we can understand what can go wrong with the immune system, evaluation and the diagnosis of CVID, as well as the differential diagnoses, and why does it matter to see if there's a different diagnosis. And then we could talk a little bit about the treatments. So what is your immune system? So your immune system is really just what protects you from infection. Even our skin, it could be considered a part of our immune system, right? So our tonsils, lymph nodes, spleen, bone marrow, all of these organs either create a barrier or they produce cells that help fight off infection. And some of these cells that are really important, these are when you get what's called a complete blood count. They look at your white blood cells. And to me, white blood cells is a whole bunch of different cells. So some of the immune cells that we're probably going to talk a little bit about are your T cells, your B cells, your NK cells, and then you have another group of cells that are a little more primitive that fight certain types of bacteria and viruses, specifically in their basophils, eosinophils, and neutrophils. So we've learned so much about primary immunodeficiency in the last couple of years. It's amazing, and a lot of that is thanks to next generation sequencing, where we can now look at a lot of genes in people. So in 1999, when we really started talking about these immunodeficiencies, they reported about 60 immunodeficiencies in about 5 categories. And then look at 2015, whereas there's 300 different primary immunodeficiencies in 9 categories. 2019, we're already over 350. So this field of primary immunodeficiency is just growing and expanding. So when we think about immunodeficiency, a lot of times, especially in our clinic, we like to think of, is this truly an immunodeficiency, or is there something else that could be going on? And so there are these public education flyers and posters that you might see around. Some of these are in our own Pittsburgh airport, and they kind of talk about what features should make you suspect that someone has a primary immunodeficiency. And I really want to focus mostly on the ones that that studies seem to show are more likely indicative of a primary immunodeficiency, and that would be the need for IV antibiotics. So requiring IV antibiotics to clear infections is a little more unusual. Having these deep-seated infections like septicemia, that's a little more unusual as well. And then a strong predictor of primary immunodeficiency, especially because, as we just talked about, their genetic is a family history of primary immunodeficiency. Another feature that seems to be very suggestive is having a failure to thrive, especially in an infant where they're not gaining good weight. That's usually something that can really tell you that this might be a PID. So to define primary immune deficiency, this is a rare genetic defect in the immune system. It's often categorized based on the organ system that's affected, and that's why I'm showing you the slide again, because based on whether you have a problem with your neutrophil production or your neutrophil function, or whether you have a T cell problem or a B cell problem, these manifest in different ways and lead us to think of different diagnoses. Today, a lot of the talk is going to be on common variable immunodeficiency. We actually consider that a defect in humoral immunity, and humoral immunity means a defect in your ability to produce antibodies, these antibodies that help fight certain types of infection. So what is common variable immunodeficiency? We think it's first reported in around 1953, and it seems to be a defect in B cell, especially maybe even B cell maturation, and the ability of B cells to produce antibodies that fight infection. So this prevalence is 1 to 50,000 to 200,000. That's actually probably a little bit older. Newer data actually suggests that common variable immunodeficiency might be as prevalent as 1 in 25,000 to 50,000. So it's getting recognized and diagnosed more, I think. The onset seems to peak in early childhood, but usually the most common time that people are diagnosed with CVID is in their 20s and 30s. So there are diagnostic criteria for CVID, and that's something we should talk about. So you have to be older than 2 years old in terms of when you have onset of symptoms. And part of that is because we don't want to call the CVID when there might be a genetic component, right? So if you present with infections very, very early on in life, to me, that's a suggestion that maybe this isn't CVID. Maybe we're looking at something genetic. So the diagnostic criteria must always include must be greater than 2 years old. You have to have decreased serum immunoglobulin of 2 different types. So you should have a low IgG, but you also need to have either a low IgM or a low IgA in order to meet the CVID diagnosis. And I think this is something that I see sometimes where someone is told that they have CVID, but they only have a slightly low IgG and they don't fit any of the other features. And that person I would call someone with hypogammaglobulinemia until further defined. So you also should have an absence of other defined immunodeficiencies, and that's a given, and then rule out other causes of low IgG. So when we get these consults for inpatient, or when we see these consultations outpatient, if there is just a low IgG, we always try to make sure that this isn't a loss problem. So protein losing enteropathy, or a patient who recently had a heart surgery, someone who might have some chylothoraces, these are all causes of losing IgG, and we would call that a secondary problem, not a primary immunodeficiency, and that's an important distinction. I think what's important about CVID is that you could have genetic testing that is negative and be called CVID because the diagnostic criteria does not require that there's a genetic finding. So that's not to say that there aren't genes that we have now found to be clearly associated with CVID, and I list some of these here that I only have 30 minutes to talk about, so I'm not going to talk about all of these, but they are all really important in B cell maturation and B cell function. And so that really nails it that this is a B cell problem that that affects the ability to produce antibodies. So CVID, what are the signs and symptoms? So classically, we look for infections, right? So especially what we call sinopulmonary infections. So those are sinus infections, ear infections, pneumonias. I always find it really unusual for a 19-year-old to come to my office and suddenly develop true bacterial ear infections, right? Or someone who's had multiple ear infections in their teens and 20s with ruptured eardrums requiring tubes. That's really unusual because we don't expect that to happen when you're older. So that's usually like a warning sign. I think sinus infections is a little bit more murky. It's hard to say what is truly a sinus infection, what's viral, what's bacterial, and how long did you wait to treat it? So what we do expect to see a lot of recurrent sinus infections and pneumonias. So that is the part of CVID in terms of infections that can cause a lot of morbidity is the recurrent pneumonias that leads to permanent changes in your lung that lead you to have even more infections in the future. So that's something to look out for and to think about in CVID. So what's interesting about CVID as well is that it's not just infection that is a problem in CVID. In fact, infection is less of a problem than it's been in the past because we've gotten really good at preventing infection. And so we're seeing a lot of morbidity or problems with autoimmune disorders, and that can be seen in quite a high percentage of people with CVID, and that's multiple systems that can be affected. So the other thing about CVID is that there is an increased risk of malignancy. It's typically in the 5th or 6th decade of life, but that doesn't mean that it can only happen in the 5th or 6th decade of life. There seems to be an increased risk of gastric cancers, but the most common are lymphomas. So for infection and autoimmunity, we talked about the places where you can have a lot of infection from CVID, but the autoimmunity can be anywhere. There's lung autoimmunity where you can have granuloma sometimes, ILD, which is difficult to treat and requires sometimes immunosuppressive therapy. You could have thyroid issues. In your gut, you could have enteropathy. So like 2 to 5% of patients with CVID might actually present with an enteropathy. Sometimes what's interesting for CVID is that these actually can precede the infections. So there are patients reported who have granulomas that look like maybe it's Crohn's or something else, who ultimately later on go on to develop the more obvious findings of CVID, including infection. Another very common autoimmune problem in CVID are the cytopenias. So anemia that's caused from your immune system attacking your red cells, low platelets, so easy bruising, and even low neutrophils can happen from your own immune system, causing the destruction of some of these cells. So to talk about treatment, so the mainstay of CVID treatment, right, the traditional treatment is to replace immunoglobulin. And I want to point something out too, is that it's excellent at preventing life-threatening pneumonias. It's getting a good level of IgG can really help protect against hospitalizations with pneumonias. But the data is still not that great on how well immunoglobulin protects you against sinusitis. And if you look at some of the recent data as well, it looks like upper respiratory infection numbers don't seem to really change significantly despite immunoglobulin therapy. So I think that's something to expect and think about before you say, oh, the IVIG isn't working. It's possible that some sinus infections may still occur, and those can be dealt with in other ways. So one way is the consideration of prophylactic antibiotics. We also do suggest to try inactivated vaccines, and so we're talking about the flu vaccine mostly because IVIG should have a lot of protection against things that we in general are vaccinated against, but flu is not something that we would typically expect to get really good benefit from IVIG. So you know, we give it, but it's unclear if that has significant benefit. But there doesn't seem to be harm in giving that. And then there's a lot of surveillance in terms of CVID that we just talked about to look for cytopenias, look for infections. So we generally follow these patients every 6 to 12 months. So just to talk a little bit about the conventional treatments in terms of immunoglobulin replacement, we have subcutaneous forms now, and we can talk about the Hizentra, Cvid are weekly, and then HyQvia is the newer one with recombinant human hyaluronidase, which is a monthly subcutaneous product. So there's more choices now than just IVIG, which is great. There's limited data about CVID and hematopoietic stem cell transplantation. And so we're not going to talk a lot about that. It has been done and it's been reported, and it's usually patients with CVID who have a lot of other complications. But the mainstay for the autoimmunity that you might see in CVID is actually, it's counterintuitive, but it is to suppress some of the immune system. So rituximab is a antibody that targets B cells. And so by cutting back on some of these B cells, which may be malfunctioning in the first place, can help with some of the autoimmunity, and we also use steroids as well. So immunoglobulin replacement is typically lifelong. And so it really first started with intramuscular injections, and that didn't really go very well. IM injections are painful, in especially in the high volumes you would need to get good IgG levels. And there was also data that we didn't giving it IM didn't really seem to get levels high enough to prevent against chronic lung infections. So then in 1981, IVIG came out, and that has been pretty much the main form of immunoglobulin replacement, and that's been working really well. But it does have some peaks and troughs, and we could talk a little bit about immunoglobulin later, since those are questions that I get quite a bit in clinic. And then subcutaneous immunoglobulin. So in 2014, there's also subcutaneous immunoglobulin, with this enzyme that actually allows you to give it only once a month, as opposed to other sub-Q that you have to give it weekly. And that is approved right now for adults. And to go over replacement, so IVIG can come in 5 or 10% forms. It is 100% bioavailability. It's dosed every 4 weeks. Usually you have to give it in the office or in an infusion center, or someone can help give it at home, but usually a nurse comes to give it. So for subcutaneous, it is not as bioavailable, so the dose is a little bit higher. It does come in more concentrated form, right, of 20%. It's dosed weekly, but one of the benefits of subcutaneous is that you can actually administer it yourself at home. And similar with hyaluronidase, except it's dosed every 4 weeks. So IVIG has been known to have some major adverse events, renal failure, thrombosis, hemolysis. So it can affect your kidneys. Thrombosis just means that it can increase your risk of clots. There have been cases of some lung injury from the infusion. These are very rare. We do see some aseptic meningitis that presents significant headaches. And then the minor forms, a lot of patients can report headaches and then just feeling not good, feeling tired. And then whether these 8 major adverse events happen also in the subcutaneous form, it's not very clear. We do know that these minor reactions are definitely more likely to happen in the IV forms than in the subcutaneous forms. And so what are the downsides of the subcutaneous? There could be a lot of infusion site reactions. In fact, most patients at some point will report some the reactions at the infusion site, and we do have ways to help with that, and that seems to get better over time as well. The systemic reactions are not common to subcutaneous immunoglobulin compared to IVIG forms, but we do have ways to deal with that as well. And then for people with needle phobia, we generally try to say to switch them over to once a month. And we can increase the volume and decrease the frequency, because some of the subcutaneous forms is not just one needle, it can be anywhere from 1 to 6 needles. So I just want to summarize a little bit about what we talked about for CVID. I think one of the most important points is that it's a clinical diagnosis. So even if genetic testing is sent and it doesn't really come back with anything conclusive, that doesn't prove that you don't have CVID, because that diagnosis can be made using clinical features. So CVID also has risk of infection, which we've been getting really good at preventing some of these more serious infections, especially also with earlier diagnosis and earlier treatment. Autoimmunity is still something that is a problem in CVID that we have ways to treat. And then there is that cancer risk, and so patients need to be seen and monitored. We talked a little bit about the different types of immunoglobulin replacements, and I want to point out that IgG doesn't really seem to prevent or fix the autoimmunity. It does prevent serious life-threatening pneumonias. So I think the second half of my talk really is about when do I suspect that there's something more than CVID, right? So there are, if you look at the criteria that I showed you with low IgG plus low IgM or IgA, having poor response to vaccine titers is another criteria. There's actually several other what we call monogenic disorders. Monogenetic meaning that that there are defects in certain genes that that relate to this disease. So there's LRBA, CD27, CTLA4, PI3 kinase, and PLC gamma 2. These diseases, the way they present, they would meet the clinical criteria for CVID, but they are not CVID and they have other features, right? So when do we think, okay, am I just going to call this CVID, or do I need to be looking for something else? So when is further workup indicated? So when I see a patient who fits the CVID criteria, right, but they have really low lymphocytes, so their T cells are very low, their B cells are very low, I wouldn't call that classic for CVID. It's been described and seen, but that always raises my suspicion that maybe I should be asking more questions and getting a really good history. So So for significant lymphadenopathy and splenomegaly, that just means big lymph nodes, big spleen, right? So there is a subset of CVID where you have a big spleen. In fact, there's people with CVID who have had to have their spleens removed for certain problems such as cytopenias. But when I see a big spleen and I see lymphadenopathy, I usually will try to see if I can find a different cause of the CVID, especially if I get a family history, right? So somebody else has a big spleen, or somebody else used to get sick like this. That really makes me suspicious. Very low memory B cells. So this is a test that pretty much only, I would say, probably mostly immunologists send, where we are not only able to look at just the total number of B cells you have, we like to see what percentage of the B cells you have, and the B cells are the ones that make these antibodies that we're looking for. What percentage of those B cells are stuck in the immature naive form, and what percentage go on to be the good ones that mature and make the antibodies that we need, right? So we have ways of measuring that. So there are some patients with CVID who don't make a lot of memory B cells, and we actually think that might correlate with having an increased likelihood to go on to have some more of the autoimmune features. But it also makes me suspicious if you have very low or no memory B cells and some of these other things we're discussing, that maybe I should be thinking outside of just CVID. And obviously family history is very important. Some of these diseases are what we call autosomal dominant. So one of the parents will present with some sort of symptoms. And then very young age of onset, right? So that's what we talked about, kids who are presenting, who are very sick with failure to thrive at 6-8 months of age. I would not call that kid CVID until I rule out other causes. And then the other thing that makes me wonder if this isn't CVID is if your IgM or your IgA are high, not low. That's a little unusual. That tells me that there's some sort of dysregulation of your immune system going on. I don't classically see a really elevated IgA or a really elevated IgM in CVID, right? But for PI3 kinase, I would see a high IgM eventually. For ataxia telangiectasia, I'll see a high IgM. So it leads me to wonder if there's something else going on. And so why does it even matter if I find a genetic diagnosis? And that's so what some of the other slides will talk about. So it really improves our ability to anticipate complications, right? And then we can reclassify a disease process that we think is this, for instance, with a patient with CTLA-4, is this poor production or is this autoimmune? And so once you get that diagnosis of CTLA-4, that you probably are going to reclassify them and say this might be more likely to be autoimmune. More specific and targeted therapies, and I think this is one of the most exciting parts of immunodeficiency, is that now we have drugs that really target the molecule or the protein or the enzyme in your body that is malfunctioning, and that's something that we really haven't been able to do in the past. So I want to give you a case about a patient that we saw, who in the beginning of life was pretty uneventful, but at 6 he came in, he was hospitalized for severe pneumonia, and he had an infection around the lining of his heart. And when he was hospitalized, they noted that he had splenomegaly, and I thought I would give you a picture of what splenomegaly means. And so if you see on the left side, it's labeled spleen. It's usually your spleen is sitting under your rib cage, so you can't really feel it. But when you have splenomegaly and your spleen enlarges, it goes down past your rib cage. So when you're feeling on your belly, you can feel it. So he had splenomegaly. He had severe anemia, and he ended up diagnosed with a hematological condition called spherocytosis. He got better. He was discharged, and he saw the pulmonologist. And when they looked down his lungs, they saw that he had a lot of pus, and they actually were unable to extubate him, meaning he required mechanical ventilation for a little bit, and he grew another organism called strep pneumo. He, after this, continued to have ear infections, sinus infections. Even though he had to have ear tubes, the infections didn't stop. He went on to have a lot of pneumonias, many pneumonias actually, from 2002 to 2005. He had 7 to 8 chest X-ray positive pneumonias that kept coming back despite antibiotics over and over. When he had imaging of his lungs at that time, he had something called bronchiectasis. So that's a dilation of the airways that can be a result from recurrent pneumonias. And so at that point, he came back to immunology in 2005, and that's when he was started on IVIG that we talked about. And so he's on IVIG, so he should be protected from infection, right? So we had some more labs done in 2007, and his IgM now is getting higher and higher, right? So that's not something we would typically think of in CVID like we talked about. He also had undetectable complement, which is another part of your immune system that shouldn't be a problem in CVID. But when we looked at his T cells seemed to work okay. Then he started getting this eye swelling that happened over and over that was occurring almost every single year, and the IVIG was not preventing that. And he went on to have significant sinus disease and required a lot of surgery. Then in 2013, he came in because he had big lymph nodes in his neck, and people were worried that it was some sort of lymphoma or cancer. He had to have those biopsied, and when he was admitted for that, that's when they really saw that he also had a lot of other things going on. He had a big spleen, he had a big liver, and he had some changes in his GI tract. And so what did he end up having? So he came to our clinic, and his features seemed really consistent with this disease. And so genetic testing was sent through our wonderful genetics team and genetics counselors here. And he ended up having a PI3 kinase P110 delta gain of function mutation. And we now call that activated phosphoinositide 3 kinase delta syndrome. So ADPS for short. So it really is a disease that was first described in 2013. So honestly, for all those times that he was having infections, it wasn't even known to be a disease. So he couldn't have been diagnosed with this when he was younger. It is autosomal dominant, and it leads to a very similar picture that he has, which we just talked about, and especially the big lymph nodes and the big spleen. It also has an increased IgM, which he had, and increased risk of infection with certain viruses. And so I'm going to just skip over some of the function slides to tell you what happened to him. So we saw that there's a clinical trial happening at the NIH for this drug, linezolid. It's actually a molecule inhibitor of P110 delta, which is exactly where his problem lies. That was something that IVIG was not going to fix. And so now he had an overactive molecule, and this suppressed it. And so what happened when he entered this trial, his spleen actually shrunk for the first time. He never had another episode of swelling around his eyes. He never had another episode of big lymph nodes. He stopped his IgG replacement. He's been making his own antibodies. His cough resolved. He said for the first time in his life that he walked 4 miles. He plays Pokemon Go a lot now, he tells me. And he says he feels full of life. And so this is the study that he is in, where you can see some of the patients here. You can see the significant decrease in the size of the spleen. And figure B, they're labeling the immune system, the lymph nodes, and how even the lymph nodes got smaller on this therapy. And so in order to be able to answer questions, I'll just try to move through, but basically some of these slides are looking at, while on this therapy, that the number of immature cells decreased, the number of mature cells went up. And so this is really a part of what's exciting about the immune system now, is that we have all this precision medicine, right? In the past, we did IVIG. If you had a T cell problem, you might get a transplant. You might get antibiotics. But now we really can target exactly what's going on. And this patient has a gain of function STAT3 mutation that was diagnosed and gets put on tocilizumab, and you can look at the incredible response in his arthritis. This patient that I'm gonna, so I'll show you the pictures. So this patient with STAT1 gain of function mutation, which previously was just diagnosed with chronic mucocutaneous candidiasis, was then started on ruxolitinib, which was a JAK inhibitor, which targeted the problem in STAT1 gain of function, and you could see that even her hair grew back, which is really amazing. And so for IPEX, for PASLI, we have rapamycin. And then I like this disease, it's called X-Men. But to know that there is a disease where you have B-cell defects and susceptible to EBV that is literally fixed with magnesium, not even like a drug, right? That's what genetic testing can tell you, and that's amazing. So management of a PID is a team effort. So rheumatology, hematology, our transplant team, ID, gastroenterology, pulmonology, our wonderful nurse outpatient coordinator, social workers. There's a lot of people, and I can't believe I didn't put genetics. So obviously genetics. So management of a PID is really a team effort. So thank you very much.
You see your question?
I think I have one question.
Okay. If
Should
you
I
just want
answer
to
the
say that, just say, oh, I have some questions. If you'd like to send a question, and here's one, and you just say, tell them the question.
Okay. So let's see. So one of the questions says, if my child needs IVIG, will they need to be on this treatment for the rest of their life? That's hard to, that depends on what their problem is, right? It depends on what their immune system issue is. So there are certain times that you might start IVIG when kids are very young. For instance, there's something that we call transient hypogammaglobulinemia of infancy, where the child might have a slow start in making their IgG, and some people in some places will, if that child is getting very sick, we'll put them on IVIG, but that patient we watch to see if they're able to make their own. If however, you have a genetic diagnosis of X-linked agammaglobulinemia, that is a maturation B-cell problem, you will never make antibodies. We know that. That's confirmed through genetic testing, and so someone like that would have to be on immunoglobulin replacement for the rest of their life. So if the question is, needs IVIG like specifically through the IV for the rest of the life, I would say now what's great is that there are so many more convenient options than just getting it through the IV. So I hope that answered questions. I'm always happy to take more questions. So how can my child get genetic testing? Okay, so genetic testing. So we here at Children's Hospital have a really amazing team of geneticists. And when I have someone who is very complex and I want genetics to help me look for genetic tests such as whole exome sequencing, they are amazing at coordinating, making and working through getting all the data that you receive when you do those tests. There's also a team of genetic counselors here through the genetic testing clinic. So if I see someone in my clinic who I think has is very likely to have something very specific that I want an answer faster and I want more targeted genetic testing, often the genetic counselors can help me with that as well. So you would probably start by getting either a referral into the genetics department, or if it's an immune system problem that you want genetic testing for, you could start through our immunology clinic, and then we would refer for the appropriate testing if indicated. So are you recommending the meningitis vaccine for CVID patients? That's a good question, because it's unclear if immunoglobulin replacement has enough protection against meningitis. So I think that's actually a really good question. I think for CVID, this is always tricky because it's hard to know if these vaccines are effective or not. Sometimes I take the opportunity, if there's someone who's been on immunoglobulin who maybe was started very young and didn't have a genetic diagnosis, and they're now making IgA that's normal, they're now making IgM that's normal, and they've been healthy. Sometimes I use, I see if I can give them a break of IVIG over a couple of months, and I use that time as my opportunity to also try to give them some vaccines, because I think that's probably the best way to give them a fair shot of reacting to vaccines. It's not contraindicated to give these killed vaccines while on IVIG. I think it's just hard to know how effective they are. So, is bone marrow transplant ever offered as a treatment? So there are definitely some case reports of CVID with bone marrow transplant, and I think after talking with Paul Sabolch, these are also, depending on the case and depending on the immunological problem, the autoimmune problem, and what else is going on. These are some cases that that we would be willing to look at and take into consideration here at Children's. But I don't think that this is standard of care for CVID specifically. I do think that's one of the benefits of genetic testing if we think that there's likely to be something else, because sometimes even in patients where we have a monoclonal antibody or some sort of biological treatment that can be helpful for that disease, if that doesn't work, and there are situations that make a bone marrow transplant feasible and a good option, then that's offered. All right. So I think that's it. And I want to say hi, Colleen. Thank you for joining the webinar. And you can always reach out to me if you have any other questions. And if you call to get an appointment, we do specifically have a clinic for patients with immunodeficiency. So you would ask for an appointment in the primary immunodeficiency clinic.